We had a really exciting annual ASCO 2019 meeting with a very exciting totality of data in both bladder cancer and kidney cancer for the non-prostate section, but also in the prostate cancer world, as my colleague will discuss in a second. In the non-prostate session, I would say that there was also data for testicular germ cell neoplasm that were interesting in terms of posters in the meeting. But if we focus our discussion on bladder cancer and kidney cancer for these particular takeaways, I will probably mention that in the bladder cancer arena, in the neoadjuvant setting, we still do not have a reliable biomarker to help us select the chemotherapy regimen for those patients. We usually either gemcitabine cisplatin or accelerated dose-dense MVAC in the clinic, and we don't have any good way to select which of those regimens. One of the abstracts by Dr. Flegg and colleagues look at that question in the SWOG 1314 trial, trying to evaluate the clinical role of a putative predictive biomarker, the Coxon score that was developed by Dan Theodorescu and others. However, in that particular study, the SWOG 1314, this Coxon score was not shown to help us select the chemotherapy regimen. So we're still in square one, having either gemcitabine cisplatin or dose-dense MVAC to choose from. And these regimens were not compared directly in that trial. The trial was not power to compare directly. However, if you look at the numbers of pathologic complete response rate, both regimens showed comparable pathologic complete response rate in that regard. Again, not power to compare, but showed some hint of comparability of the two regimens. It's important to note that we do not use carboplatin for neoadjuvant or adjuvant setting for localized bladder cancer. So patients who cannot get cisplatin-based combination chemotherapy, those patients are better served going in a clinical trial before cystectomy, or to cystectomy alone, or in select patients, chemoradiation for bladder preservation. And there is an important trial there, the SWOG NRG 1806, comparing chemoradiation alone with chemoradiation plus atezolizumab as a phase 3 trial to try to improve upon chemoradiation alone for bladder preservation. So it's important to keep an eye for those clinical trials in that setting. And there is a plethora of neoadjuvant and adjuvant clinical trials that are very important and hopefully will in the future potentially change the way we treat this disease. But for now, cisplatin-based combination chemotherapy is a standard of care before radical cystectomy, if that's a pathway we take. If we move our attention to metastatic urothelial cancer, a few highlights from the meeting. One abstract by Dr. Rosenberg and colleagues evaluated the addition of bevacizumab anti-VEGF to the backbone of gemcitabine and cisplatin chemotherapy, randomized phase 3 trial by the Alliance. It took a lot of time and effort to do this trial, so the authors should be congratulated, all of them. This trial did not show any overall survival benefit with bevacizumab added to gem-cis chemotherapy, so it did not change practice. It was a negative phase 3 trial. Another very important study in the switch maintenance setting after someone gets platinum-based chemotherapy first line. The question is, do you wait until progression after the complete chemotherapy, or there is any role of doing a switch maintenance approach? And if there is no progression, do you use checkpoint inhibition to prevent progression and prolong survival? In that context, Dr. Galsky and the Hoosier group did a very important study, looked at patients who had no progression, meaning they had response or stable disease, in patients who got first-line platinum-based chemotherapy, and they randomized those patients to either pembrolizumab, anti-PD-1, or placebo with a crossover design. It was a relatively small study, about 100 patients or so, and showed by iRECIST a prolongation, statistically significant, in progression-free survival with pembrolizumab versus placebo, and also some response rate that were delayed after the end of chemotherapy with a pembrolizumab arm higher than the placebo arm. However, it's a small study, relatively speaking, about 100 patients, and with a crossover design, it will be very hard to show an overall survival benefit. And considering potential side effects and cost, I think this study is very important. The authors should be congratulated, but it's probably too early to change practice. Probably we'll have to wait for phase 3 trials, like a big phase 3 trial there with avelumab versus best supportive care, exactly in the same setting, has finished accrual. The results are pending. So I would say we'll have to wait for this bigger phase 3 trial to put in context with Dr. Galsky's trial to see whether or not the practice will change in the future. I think very interesting data, but probably not practice changing today, but very promising. The third important abstract in metastatic disease is a study by Dr. Petros and colleagues evaluating the antibody-drug conjugate enfortumab vedotin, very interesting compound and antibody-drug conjugate against Nectin-4. And this antibody-drug conjugate showed very impressive overall response rate by objective imaging criteria, about 40%. Very exciting response rate in these patients who had prior treatment with platinum-based chemotherapy and checkpoint inhibitor. So comparing very favorable with historical data with cytotoxic chemotherapy, with single-agent taxane, for example. So this phase 2 trial showed very high promise with this antibody-drug conjugate enfortumab vedotin. The data is being submitted, I think, to the FDA for review. It might potentially lead to accelerated approval. We have to see. And there is a phase 3 trial with enfortumab vedotin, the same compound, compared to chemotherapy, taxane chemotherapy, or vinflin chemotherapy, I suppose, in Europe, that can answer the question definitively whether this compound is superior to chemotherapy. But based on the phase 2 data, definitely very, very promising and potentially practice changing in the near future upon regulatory review. Important to note potential adverse events with every agent, and this antibody-drug conjugate, can have some side effects. Some of them were highlighted by Dr. Petros, like neuropathy, RAS, hyperglycemia. There are things to keep an eye on, among others, when this agent could potentially be approved in the future, how to recognize and manage these adverse events down the road. Another antibody-drug conjugate looks very promising. It's called sacituzumab govitecan, or IMMU-132, has very promising data in triple-negative breast cancer, and also there was a phase 1 study presented recently in urothelial cancer by Dr. Tagawa, and there is an ongoing phase 2 trial with this antibody-drug conjugate in advanced urothelial cancer in patients who had prior treatment. So overall, antibody-drug conjugates are very, very relevant in this disease, and more data are coming soon. At the same time, we have a recent approval of a targeted therapy in advanced urothelial cancer, an agent called erdafitinib, an FGF receptor inhibitor based on FGF receptor 2 activating mutations or fusions. And there is a companion diagnostic assay that can be used to select those patients who have already prior platinum-based chemotherapy and they have mutations or fusions in this tumor, FGF receptor 2 or 3, and these patients could potentially get erdafitinib, a newly approved FGF receptor inhibitor in that setting, based on phase 2 trial data presented at ASCO last year, but the approval came recently on April 12, 2019, and there is an ongoing phase 3 trial with erdafitinib compared to chemotherapy or with pembrolizumab. In that regard, we're going to have the data hopefully in the future, but definitely an option for those patients with the first targeted therapy ever approved with erdafitinib in advanced urothelial cancer. Briefly, to comment on the very exciting landscape of kidney cancer, in the first-line setting, we have 3 new regimens approved recently: ipilimumab, nivolumab, pembrolizumab, axitinib, and avelumab axitinib, based on 3 very important trials. The Checkmate 214 was ipi-nivo, Keynote 426 was a pembroaxi, and the Javelin Renal 101 was the avelumab axitinib. And all these 3 regimens appear really efficacious and appear to be superior compared to sunitinib, that was the control arm in all of those studies. The data with ipi-nivo and pembroaxi showed superiority in terms of PFS and overall response rate. The nuance here is that in the ipi-nivo versus sunitinib trial, the good risk patients, there was no overall survival difference between ipi-nivo and with sunitinib. The same goes with pembroaxi and avelumab axitinib in all 3 trials. And the question here is, in favorable risk patients, you have less events, less deaths, people live longer, have better prognosis, so it's more difficult to show differences. However, the response rate and PFS in the initial data cut for the ipi-nivo versus sunitinib study actually favors sunitinib. So in the good favorable risk patient population, someone could potentially think about using pembrolizumab axitinib or available axitinib, because there was overall response rate, numerically at least, favored the combination over sunitinib. Intermediate and poor risk patients, I think all these options are reasonable. The available axitinib trial did not show overall survival benefit yet in the interim analysis, but it's ongoing follow-up that is happening. So overall, 3 very important regimens: ipi/nivo, pembro/axi, available axitinib. There are some nuances, that the audience can read out in the virtual meeting, and also some interesting data was presented regarding the Carmina trial that looked at cytoreductive nephrectomy before sunitinib. Interesting updates based on the IMDC Henk criteria. I think it's interesting for the audience to look at that abstract to see that patient selection is really key when you have to decide about cytoreductive nephrectomy based on the risk factors, based on Henk criteria. If you, for example, you have one risk factor, it's a case-by-case discussion in a multidisciplinary tumor board, cytoreductive nephrectomy or not. If you have 2 or more risk factors, usually these patients may not get cytoreductive nephrectomy based on this data. It's a risk factor, of course, analysis, and these patients should, especially with good risk and or one risk factor by MDC criteria, are better served with tumor boards and multidisciplinary discussion. But again, with intermediate 2 or poor risk patients, probably systemic therapy alone is the usual way to go based on that data. And then there is some data that we saw regarding non-clear cell RCC, some interesting data with pembrolizumab alone that showed some efficacy, 25% response rate in non-clear cell histologies, single agent phase 2 study, the KEYNOTE-47. And there was also some interesting data that were shown with ipi/nivo as well as with pembro/axi in patients with sarcomatoid features. RCC that also showed some efficacy with these combinations, again, ipi/nivo or pembro/axi, those patients with sarcomatoid features, which represents a very aggressive variant of kidney cancer. Overall, I would encourage the audience to look at the virtual meeting. Very exciting data. It's important to think about also germline mutations, both in urothelial and kidney cancer. Take a good family history, personal history, look at age of diagnosis. Upper tract disease may have more urothelial cancer, may have higher chance of germline mutations, so another factor to keep in mind. And overall, a lot of great clinical trials to follow upon and also enroll patients. So definitely keep an eye on clinical trials and try to enroll patients in those. So thank you so much for having me.